Hello friends, today the topic of talk is intracranial cysts, their diagnosis and differentiation. Why we have chosen this topic? Because intracranial cyst is one of most common finding on sonographic evaluation of fetal brain. It is easily detected due to obvious anechoic appearance at places where it should not be present. Prognosis varies from normal benign variant that egresses spontaneously to poor one. Larger cysts may exert pressure on adjacent organs, causing displacement of structures or obstruct the flow of CSF. Mostly it is isolated but can be associated with other pathologies. For diagnosis, we can use ultrasound. By ultrasound, we can check location, size, relation to ventricles and midline structures. Detection of solid component in case of brain tumors or blood clots, or by Doppler studies to assess blood flow pattern in case of vascular malformation like aneurysm of vein of Galen, as well as assessing location of cyst in relation to internal cerebral vein. MRI can be offered for morphological evaluation of cyst and relation to ventricles and brain cortex as supplement to ultrasound evaluation. Because in advanced gestation age, ultrasound evaluation may be impaired by calcified fetal skull and relatively small fontanelle. MRI can be used for detecting migrational disorders in places distal to cyst like Schizanencephaly or intracranial hemorrhage. Histological examination is helpful when both USG and MRI may fall short in identifying lesions. There are many types. It is of extraaxial when lesion is located outside the brain parenchyma. It can be arachnoid cyst, glioependymal cyst, endodermal cyst, cystic teratoma, vein of Galen aneurysm, dural separation due to dural sinus thrombosis, and dural sinus malformations. They can be benign cystic lesions like cavum velum interpositum, cavum septum pellucidum, cavum Purkinje. Intracranial cyst can be intraaxial, that is a lesion in the brain parenchyma or within the ventricle. It is termed intraaxial. It can be periventricular pseudocyst, periventricular cystic leukomalacia, porencephalic cyst and cystic tumors. It is called intraventricular cyst when it is seen within lateral ventricles. These are choroid plexus cyst, colloidal cyst and ependymal cyst. Let's talk about arachnoid cyst. Incidence is 1% of all intracranial masses in children. It is more common in males. It is most common pathological lesion in extraaxial origin. These are collection of CSF located within layers of arachnoid membrane and bordered by cyst wall and may or may not communicate with subarachnoid space. The subarachnoid space surrounds the brain and spinal cord, and in certain location it enlarges into expanded area. It contains CSF and blood vessels. These expanded areas are called subarachnoid cisterns. Arachnoid cyst can develop near or within these cistern spaces. Most common sites are this is chiasmatic cistern or suprasellar cistern. Another is cerebellomedullary cistern or cisterna magna, and one is near the great cerebral vein, cistern of vein of Galen or superior cistern or quadrigeminal cistern. These three are most common sites for subarachnoid cyst. How they are formed? Primary cyst formed by disturbance of mesenchymal neural crest, the origin of meninges, which form a splitting of primordial membrane into which fluid accumulates and become loculated like dissecting aneurysm. And secondly, arachnoid cyst formation results from entrapment of CSF within arachnoid adhesion after in utero hemorrhage, infection or trauma. Recurrence, it is not associated with increased risk in future, but if associated with few hereditary condition like Aicardi syndrome, which is X-linked dominant, there is increased risk of recurrence. Associated lesions are mostly arachnoid cysts are isolated, but these can be associated with CNS anomalies in 46% cases like obstructive ventriculomegaly, which is most commonly seen in 2/3 of cases. Agenesis of corpus callosum, absent CSP, deficient cerebral lobulation, Arnold Chiari type 1 malformation, MCD, and arteriovenous malformations. Non-CNS anomalies have also been reported like distichiasis lymphedema and Mohr syndrome as well as 12q24:31 deletion. This is a midline arachnoid cyst along with agenesis of corpus callosum and CSP is also absent here. Another risk of syndromic condition is typical condition associated with arachnoid cyst is Aicardi syndrome, which is an X-linked dominant syndrome which include agenesis of corpus callosum, interhemispheric cyst, choroid anomalies, heterotopias, cerebral hemiasymmetry, and other cerebral malformation plus female gender. Sickle syndrome can also be associated, which includes severe IUGR, marked microcephaly, and a characteristic bird-headed facial profile with micrognathia along with arachnoid cyst. This we can see a huge arachnoid cyst in parieto-occipital region along with bird-headed appearance and micrognathia, diagnostic of sickle syndrome. By ultrasound, we can diagnose arachnoid cyst as single isolated lesion, anechoic cyst, mostly in midline, not connected to lateral ventricles. It is usually associated with corpus callosum. Here it is seen with corpus callosum and agenesis. Mostly it is seen in midline. This is a large cyst, but we can also see in posterior fossa. Like here we can see in posterior fossa near the cerebellum. These do not communicate with lateral ventricle. It is seen as extraparenchymal sonrodusum cystic mass. They have mass effect compressing the adjacent cerebral structures. Secondary hydrocephalus may be seen due to obstruction in flow of CSF. Left side of brain is affected more commonly. Mostly arachnoid cysts are supratentorial, located in middle cranial fossa around 50 to 65%. They can be seen in suprasellar cistern 5 to 10%, in quadrigeminal cistern again in 5 to 10%, in posterior fossa in 5 to 10% related to cerebellopontine angle and cisterna magna. In 5% it is seen at brain convexity. In other studies, it was found around 63% are supratentorial and 22 are infratentorial. Multiplanar image correlation is important for adequate location assessment, and color Doppler may also help when cyst is located in cistern crossed by main artery. Here we can see this is suprasellar cistern, this is quadrigeminal cistern, this is midline interhemispheric cyst. Here we can see arachnoid cyst in posterior cerebral fossa, same along the side, compressing the cerebral parenchyma. This is arachnoid cyst in temporal part of the cerebral cortex, temporal arachnoid cyst, displacing the vessels along with. And here we can see arachnoid cyst in it is axial plane near the cerebellum, posterior fossa of the brain. Again, in the mid-stage view, we can see near infratentorial arachnoid cyst is there, and in cornal plane also we can see infratentorial. It is compressing the cerebellum also. Differential diagnosis is porencephalic cyst. It is seen in brain parenchyma, mostly communicates with ventricle, and it is rarely with subarachnoid space. It is clastic, formed by destruction of white matter, mainly by hemorrhage. It may be associated with ventriculomegaly. In comparatively, arachnoid cyst shows mass effect. Porencephalic cysts do not show any mass effect. Brain parenchyma is normal here. In schizencephaly, abnormal clefts lined by dysplastic gray matter involving lateral aspect of cerebral mantle extending from surface of brain to inner fluid cavities are seen. These may be unilateral or bilateral, symmetrical or asymmetrical. When bilateral, 60% are open-lipped. Closed-lip schizencephaly cannot be diagnosed by ultrasound. A vascular disruption is likely pathogenic mechanism. These are usually associated with another CNS lesion like gyration disorder like polygyria and pachygyria. Another is periventricular cyst. This can be subependymal cyst or pseudoventricular cyst. This is small cyst below the lateral ventricle and posterior to the foramen of Merlo. They frequently persist following grade 1 germinal matrix hemorrhage which is associated with prematurity. These have a good prognosis. Conator cysts, these lie anterior to foramen of Monro at or below the lateral ventricle and are due to folding of ventricular wall. These resolve spontaneously with time. Another is cystic periventricular leukomalacia. These leukomalacic cysts are very dangerous. They carry poor prognosis because these are indicative of hemorrhage, brain hemorrhage. It has poor prognosis because of volume loss of involved white matter, which often leads to cerebral atrophy and later which leads to cerebral palsy. And if grows, it can lead to porencephalic cyst also. Malformation of vein of Galen seen as white structure above cerebellum in the area of quadrigeminal plate cistern. Aneurysm represent a remnant of embryonic median prosencephalic vein. Diagnosis is made by color Doppler showing dilated vein with turbulent flow. It does not communicate with ventricles or the subarachnoid space. Additional feature finding we may find ventriculomegaly, cardiomegaly, tricuspid regurgitation, ascites, degree reversal indicating high output failure. Glioependymal and endodermal cysts are extremely rare and cannot be distinguished by sonography from arachnoid cysts. They can be differentiated histologically by their glioependymal lining. They may be located both extraaxially as well as intraparenchymally and have been reported to be associated with agenesis of corpus callosum. Most cases are located in spinal column and of intracranial mostly are in posterior fossa. This lesion is thought to arise from displaced neuroectodermal tissue, most closely resembling the area forming the tila choroida. Brain cystic tumors. These are extremely rare and have a heterozygous pattern and are usually within the brain parenchyma and may communicate with the ventricles as compared to arachnoid cyst which does not communicate with ventricles. Teratoma is probably only tumor that may appear as completely cystic, intracranial, extraaxial neoplasm. They can be large enough to occupy most of the intracranial space, like here we can see they occupy most of the intracranial space. No brain structure is identified separately, plus they are having impressive vascular supply. From Megacisterna magna and Dandy-Walker malformation, it is extremely difficult to differentiate arachnoid cyst in posterior fossa from Megacisterna magna or Dandy-Walker malformation. Main feature of arachnoid cyst is cyst compressing the cerebellum against the brainstem with vermis intact. Here again it is compressing the cerebellum unilaterally with vermis intact. In Megacisterna magna, there are no signs of compression. In Dandy-Walker malformation, vermis is hypoplastic or absent. So size and morphology of vermis should be assessed in mid-sized transvaginal or MRI. Now thrombosis of dural sinus and thrombosis of torcular hydrophyllae. Following a thrombotic event, these are rare events that are thought to result from trauma, dural sinus malformation or genetic thrombophilia. This lesion displays both solid as well as cystic components. Separation of dura with cyst-like area at the level of torcular hydrophyllae containing a locus of clotted blood can be seen in prenatal ultrasound. Thrombosis in acute state is hypoechoic, not seen as echogenic content. Dural sinus dilation and lack of color Doppler, these are diagnostic of thrombosis. Now for CSP and Cavum-Burki. These are physiological median brain structures that may appear as cystic lesion on axial plane of brain, caudal to corpus callosum, and between the two lateral ventricles. Cavum-Burki is in continuity with the CSP. These cavities are formed by sheets of septum pellucidum during morphogenesis of brain. As midline structures start closing from posterior direction, Cavum-Burki closes first. Delayed closure appears to be a normal variant with normal outcomes. In multiplanar evaluation, in axial plane, we can see CSP as an elongated midline cystic lesion, and in sag plane, we can see Cavum-Burki as continuation of CSP, which is not yet obliterated and appears dilated. Now cavum intervilli postae system. This is anechoic midline CSF filled interhemispheric cyst located in cavum villi interpostae posterior to thalamus. CVA is median potential space positioned inferior to hippocampus, splenium, column of fornix and superior to tila choroidea. Here it is seen posterior to splenium and fornix but superior to tila choroidea. Color Doppler may differentiate between CVI cyst and arachnoid cyst in quadrigeminal system by checking internal cerebral vein. As CVI cyst is 2.5 to 4 mm away from quadrigeminal plate, it is seen above the internal cerebral vein. Like here we can see internal cerebral vein is below the cyst and cyst is above. But arachnoid cyst is below the internal cerebral vein. Internal cerebral vein is seen superior to the quadrigeminal cyst. Dilation of CVA space is thought to be a normal variant associated with normal outcome. Here again we can see cavum villi interpostae cyst seen in the midline as interhemispheric cyst. When we do multiplanar, put a dot, we can see in sag plane, dot is seen posterior to splenium and superior to the tila choroidea of third ventricle. Now the choroid plexus cyst. Choroid plexus cysts are most common type of intraventricular lesions. This is a fluid-filled cystic space that accumulates within choroid plexus. It is seen in 1 to 2% of fetuses in second trimester. As many as 50% of fetuses with trisomy 18 have choroid plexus cyst. Mostly these are isolated, but meticulous scan to look for fetal structure malformation and soft marker for trisomy 18 should be done. These anomalies include congenital heart formation like VSD, polyvalvular dysplasia and coarctation of aorta, brain anomalies like holoprosencephaly, meningomyelocele, Arnold-Chiari malformation, abnormal gyration and hydrocephaly, facial anomalies like low-set tears, micrognathia, cleft palate, renal anomalies like horseshoe kidney, hydroureter and hydronephrosis, skeletal anomalies, clenched hand, rocker bottom foot, club foot, with nuchal thickening, cystic hygroma, polyhydramnios and single umbilical artery. How they are formed? Choroid plexus is responsible for the production of CSF. These cysts are thought to result from filling of neuroepithelial folds with CSF, a portion of which are pinched off and become tubules or cysts within the choroidal matrix. Most of these lesions resolve spontaneously by third trimester and do not recur in subsequent pregnancy. Although rare case of obstructive hydrocephalus due to large CPC or compression of foramen Monro has been reported. Even cases of CPC associated with trisomy 18 are sporadic and risk of recurrence is not significantly higher. However, familiar translocation have a high recurrence risk based on specific translocation. In USG, we can see choroid plexus as sonotubescent structure within hyperechogenic choroid plexus. These are usually small, less than 10 mm in size with a range of 3 to 20 mm. These can be seen unilateral or bilateral and they can be unilocular or multilocular cyst. And they contain debris or other cyst-like structures. Closed DD is choroid plexus hemorrhage, which has hyperechogenic appearance in first 72 hours, after which it becomes less echogenic as blood dissolves. Choroid plexus papilloma also present as cystic structure in choroid plexus. In prenatal management, diagnostic testing such as amniocentesis for fetal karyotyping is recommended when additional fetal structure malformations are detected. In isolated cases, it is recommended as normal variant and testing is not recommended. Prognosis of arachnoid cyst depends on size of cyst, its location within the brain. 60 to 80% of arachnoid cysts are asymptomatic. Prognosis also depend on associated congenital or chromosomal anomaly. Prognosis if it is isolated, it is very good. Isolated benign appearing cyst of median structure like CVA cyst, CSP and Cavum-Vargi carry a favorable outcome. Now, prenatal management of arachnosis. Detailed fetal scan for extracranial anomaly should be done along with fetal echo. Follow-up neurosonogram should be done in order to monitor growth of arachnosis, to diagnose other intracranial anomalies and obstructive hydrocephalus if this develops in late gestation. MRI can be used as complementary imaging to get significant information in arachnosis, especially if cerebral anatomy is distorted by large cyst. Color Doppler to be done to check midline vascular cyst and to assess location of cyst in relation to internal cerebral veins. Diagnostic testing with amniocentesis and chromosomal microarray analysis should be offered, especially if arachnoid cyst is not isolated. If there are additional anomalies, consanguinity, or a family history of specific condition, gene panel testing or whole exome sequencing is sometimes useful. Mode of delivery is not affected unless hydrocephalus is there inhibiting vaginal delivery. For the postnatal management of arachnosis, most arachnosis can be managed expectantly and have favorable outcome. Patients who are symptomatic like showing psychomotor neural behavior disturbance, there is surgical treatment indicated. Surgical options include ventriculoperitoneal and cystoperitoneal shunting, open or endoscopic fenestration, and stereotactic aspirations. Long-term prognosis after surgery is good. Around 64% after surgery has a complete recovery. These are my references from where I have taken the content.